Hello and welcome to your Chapter 9 video lecture on joints. Our chapter objectives are going to be discuss both functional and structural classifications for body joints, to describe the characteristic features for fibrous, cartilaginous, and synovial joints and give examples of each. We want to define and identify the different body movements and discuss the structure of specific body joints and the movements allowed by each. And lastly, explain the development of body joints. So we'll start off with a little bit of an introduction. Our joints are the location where our bones come together, and this will allow an area for movement to take place, and it's joined by connective tissue or cartilage, which is a connective tissue type, or synovial structures, which we will get into more detail on those in the following sections. We also have this stability rule where if a joint has more movement, it means that that joint is less stable and vice versa. So if we have less movement, then that joint is more stable. We'll start off with section 9.1 on the classification of joints. But once again, let's define what a joint or articulation is. It's going to be any place where bones come together with cartilage to form a connection. And so we can classify joints in two different ways, functionally and structurally. Our structural classification is based on shape. So if they are anchored strongly by connective tissue or cartilage, or if they're articulating with a fluid-filled space known as a joint cavity. We can also classify functionally based on the degree of movement we have between the bones. We can have immobile or slightly movable joints that will serve to protect internal organs and give stability, or we can have joints that are freely movable that'll allow extensive movement of the body and the limbs. So let's dive in deeper to our structural classification. There are three categories for structural classification: fibrous, cartilaginous, and synovial. Our fibrous joints are going to be when we have bones coming together that are united with a fibrous connective tissue. So an example of this would be the sutures of the skull. Our cartilaginous classification means that the bones are joined together by hyaline cartilage or fibrocartilage. And examples of this would be our costal cartilages, which would be made up of hyaline in the thorax. Lastly, we have our synovial joints. These are going to be our articular surfaces of bones that are not directly connected, but do have a joint cavity filled with lubricating fluid known as synovial fluid. So I'm going to go back to show you that this is what a synovial joint looks like. We could see those bones aren't particularly touching. We've got a space in here and it's filled with that synovial fluid. And so with this type of joint, we are going to have free movement, and it's the most common type of joint we have within our body. A good example of it would be our knee joint. Now we're going to switch from structural classification, which again was based on shape and the types of cartilage that we are going to have, whereas functional classification is based on the movement, the range of movement that we're going to have. So again, we're going to have three categories. First category is our synarthroses type joints. This means that the joint is immovable. There's a strong union between the bones. In fact, arthroon means to fasten by a joint. So that's why we see that term kind of throughout each of these. And the example for a synarthrosis type of joint would be the sutures in the skull, which we see over here. Another example would be the manubriosternal joint, where we have the body of the sternum come together with the manubrium, and that would be a cartilaginous joint because we would have some hyaline cartilage in there. Then we have our functional classification, which is ampiarthroses joints. These will be slightly movable or will have limited mobility. Examples would be our intervertebral joints, which could be a cartilaginous joint, and the intervertebral joints we're talking about are made up of fibrocartilage, but we'll discuss that a bit more later. And the other example would be the pubic symphysis, where those two pubic bones come together as a part of the pelvis. And that too is structurally classified as a cartilaginous joint. It too is made up of fibrocartilage. And our last functional type is going to be diarthrosis. This is a joint that is freely movable and can be divided into 3 axes of motion. And essentially, it consists of all synovial joints, mostly within our appendicular skeleton, so within our limbs. And we can also talk about these axes of movement that we just referred to in our diarthroses joints. So that's referencing to our transverse, frontal, and sagittal planes. When we have a uniaxial joint, this means that we have motion just taking place around a single plane and one axis. So an example would be the elbow joint, in which we would have movement of flexion and extension within our sagittal plane. If we have a biaxial joint, with bi, we want to think 2, so we're having motion in 2 planes. An example of that would be our metacarpophalangeal joint. So it's where the metacarpal meets the phalange, the proximal phalanx, or some of us know this as the knuckle joint, and we are able to do flexion and extension at that joint, as well as abduction and adduction by spreading the fingers apart and pulling them back together. The last type is going to be called a multiaxial, polyaxial, or triaxial joint, in which we allow motion in 3 planes. So good examples of that would be our hip joint, which would allow for flexion, extension in our sagittal plane, abduction and adduction in the frontal plane, and rotation, which would take place in our transverse plane. Another example would be our shoulder joint, which can also complete all of those movements. So now we're going to go even deeper with our structural classification. Let me just go back a couple slides here. Remember, structural classification were our fibrous joints, cartilaginous joints, and synovial joints, and they were based on shape. Remember that our fibrous joints were named so because they have connections from bone to bone due to the fibrous connective tissue in there. There's going to be no joint cavity present. And we have 3 subcategories of fibrous joints. We have our suture joints, which we can find between the bones of the skull. Our syndesmosis joint, which we would find in bones that are more widely separated and held together with a narrow fibrous connective tissue, which would consist of a ligament or the interosseous membranes we find in the forearm and the leg. And lastly would be the gomphosis, and this is a specialized joint that we find in the roots of tooth and bony sockets in the jaw. So you can see that right along in here. So we're going to go through each of these subcategories of fibrous joints next. So we talked about sutures, and this includes all the bones of the skull except for the mandible, which we'll talk about in section, I believe it's section 5. And we aren't going to have any movement take place here, or maybe just a little bit of a slight movement. Fibrous connective tissue will bind or sew these together, and it strongly unites them. We have these interdigitations that just fit together like a perfect puzzle. And these are functionally classified as synarthroses because it's immobile. Now, when we look at these areas in infants, we'll see that that connective tissue between the bones are going to be wider and known as fontanelles. We've got the anterior fontanelle, posterior fontanelle, mastoid fontanelle, and sphenoidal fontanelle. And these are here to provide flexibility when that head is moving through the birth canal during labor. But after the baby is born, it will cause the skull to rapidly grow and the brain to enlarge, and the fontanelle size will decrease within the first year, and we can then call these joints sutures. Now, as we age, these sutures are going to ossify, and cause adjacent bones to fuse together, and this is going to be called a synostosis. Next, let's talk about the subcategory of syndesmosis joints. This is when we have two parallel bones, like we have here in the forearm, that unite by a fibrous connective tissue. It could be joined together through ligaments or this interosseous membrane in here. The interosseous membrane is a broad sheet of connective tissue that we find again in the forearm between the ulna and the radius, or we can find it in the leg between the tibia and the fibula. It can also even serve as an area for muscle attachment. Functionally, we can classify these joints as amphiarthrosis because we can have some movement that will allow some rotation within the forearm, or within the leg, we can have that talus lock in place in the ankle joint, and that gives it strength and stability during weight bearing. And the last type of fibrous joint is going to be the gomphosis. This means fastened with bolts, and it's also referred to as a peg and socket joint. It really helps to anchor that root of the tooth into the bony socket, and will take place in the maxilla, the upper jaw, and the mandible, which would be the lower jaw. Now in here, we can't really see an illustration of this, but along in here we're going to have these tiny periodontal ligaments, and these are just short bands of dense connective tissue that'll span from this bony wall, let's say it's of the mandible, to the root of the tooth. And functionally we would classify this as synarthrosis because we do not want movement to take place here. Now let's move into our next structural classification, which is our cartilaginous joint. These are going to consist of adjacent bones that are united by either hyaline cartilage or fibrocartilage. So we still do not have a joint cavity, and we're going to have two subtypes. We have our synchondroses, which are going to be when our bones are joined by hyaline cartilage. So an example of this would be the anterior end of the rib and costal cartilages of the thoracic cage that help it communicate with the sternum. And the other subtype is called asymphysis. This is when our bones are joined by fibrocartilage, and the best example of that is this pubic symphysis joining our pubic bones. So let's dive deeper into each of those subtypes. Our synchondroses type of joints are going to be the ones that were joined by hyaline cartilage, and we classify them as synarthroses because no movement takes place. These can either be permanent or temporary. So let's talk about some of the temporary versions of this joint first. We've talked a little bit about the epiphyseal plate already, also known as a growth plate, where we are going to have some cartilage, hyaline cartilage to be specific, sitting between the diaphysis and the diaphysis down here and the epiphysis up here. And that is really going to assist in allowing this bone to grow in length. And then later on, as we age within our late teens or early 20s, this hyaline cartilage is going to be replaced by bone and will become the epiphyseal line. And this fusion of the epiphysis and the diaphysis, once again, when things like this ossify, we are going to call it synostosis. Now, if we were to injure this epiphyseal plate before it becomes the line, it can hinder this bone from growing in length. This actually, unfortunately, happened to my dog. We're not sure if it happened before or after we got him as a puppy, but he ended up having a damaged growth plate in his forearm, so his ulna continued to grow, but his radius stopped growing, and so his front paw kind of curves out because of this difference in length. So moving on from there, another area where we see temporary synchondrosis joints is within the hip. And this is going to be when the ilium, ischium, and the pubic bones are growing layers of cartilage during childhood and adolescence, and then it starts to become replaced with bone as the body stops growing, and we can call this a synostosis once again. Sacrum, or our coccyx, and how that is going to be made up of fused vertebrae. Other times we will have more permanent types of joints, such as the first sternocostal joint. This is when we have the first rib anchored to the manubrium here of the sternum by costal cartilage. You can see that cartilage a bit better over here. And then we have the anterior ends of the other 11 ribs that we have that join the sternum via costal cartilage. Now for the second type of cartilaginous joint, the symphysis. This is when our bones are joined together with fibrocartilage, and that fibrocartilage can contain numerous bundles of thick collagen fibers. This allows it to have a greater ability to resist pulling and bending. And we can functionally classify it as amphiarthrosis. This means that there is some movement taking place, and our examples were the intervertebral discs that sit between the vertebral bodies, as well as the pubic symphysis. Now, the gap can either be narrow or wide within these joints. If it's narrow, like it is within the pubic symphysis or the manubriosternal joint, we may have a lesser degree of movement. Whereas if it is wide, such as in the intervertebral symphysis, where we have joining of the vertebral bodies and those intervertebral discs, we can have some small movements and also cushion between the vertebral bodies. Now let's move into our last structural classification, which are synovial joints. This is the most common type of joint within our body, and at this point we do have that joint cavity present. Remember, it's filled with fluid within this space where the articulating surfaces are going to contact or come much closer to one another. These surfaces, again, are not directly contacting each other, but they are close in proximity, and this will allow us to have more joint mobility. We can functionally classify all of our synovial joints as diarthroses because they will be freely movable joints. Now let's take a look at some of the structural features of synovial joints. Surrounding the entire joint, we are going to have a double layered articular capsule, which we also call the joint capsule. The inner layer of this capsule is going to be called the inner synovial membrane, and this is a thin layer that is going to secrete the synovial fluid. Synovial fluid is going to be thick, slimy fluid for lubrication and nourishment of the articular cartilage, because our cartilage is not, I should say our cartilage is avascular, so we have to get nourishment through some fashion or form. So in here it's due to the synovial fluid. Now this articular cartilage that sits along the surfaces of the bone is just going to be that thin layer of hyaline cartilage and is there to prevent friction between the bones, and it allows it to have smooth movement of the joint. Like I said, it is avascular, meaning it does not contain blood vessels. And within or surrounding our synovial joint, we may have some ligaments. These are strong bands of connective tissue that are fibrous in nature, and they will be very strong and give support to the joint by anchoring the bones together. And in this way, we are going to limit the range of motions. In addition to limiting that range of motion, we will have muscles crossing around this joint that can also limit the range of motion. So let's talk about the three different classifications of ligaments. First, we have our extrinsic ligaments. These are going to be located on the outside of the articular capsule. So a good example would be like this patellar ligament here. Our intrinsic ligaments are going to be fused or become incorporated into the wall of the articular capsule. So an example of that would be like our medial collateral ligament or that medial meniscus. And then we've got our intracapsular ligament that's going to be located inside the articular capsule. So a good example of that would be the ACL, anterior cruciate ligament, here in the knee. We also, remember, have muscles surrounding this joint. So with those muscles come tendons. And a tendon is going to be a dense connective tissue attaching muscle to the bone. When forces are placed on the joint, the muscle's going to contract, crossing the joint to increase the overall strength, and it helps to serve as a dynamic ligament. So this is really seen within the quadriceps femoris muscles that we find on the anterior thigh. Here's our quadriceps tendon moving on down. It encases our patella and then becomes the patellar ligament or tendon that then attaches to the tibial tuberosity. Another unique feature that we can find is an articulating disc or articular disc that we may find within some specialized joints. And this is made up of fibrocartilage and typically will be small and oval shaped and acts to unite the bones of the joint. Examples would be in our sternoclavicular joint, between the sternum and the clavicle, of course. And in other areas, it can provide shock absorption and cushioning between the bones. So for example, we just talked about the menisci in the knee, or I mentioned the medial meniscus at least, and how that is going to cushion that femur sitting on top of the tibia and are typically going to be larger and C-shaped. In the case of the knee, we'll also see that it'll be a little bit thicker in the periphery and thinner internally. And it can also smooth out our movements between our bones. A great example of that is our temporomandibular joint here that allows our mandible to do things like elevate and depress, bringing that jaw up and down. Or even lateral excursion, so like that grinding movement of your jaw. Some other features we see around the synovial joint are fat pads, and these are structures that serve as a cushion between bones. And something else that can cushion and reduce friction are bursa. So here is an example of one, the suprapatellar bursa. A bursa is a thin connective tissue sac filled with a lubricating fluid. So this word bursa actually in Greek means purse, which is very close to the word in Armenian for purse, which is baisag. Baisag. So I always just think I'm carrying my baisag or my bursa around with my fluid, lubricating fluid within it, the synovial fluid-like substance. So where are we going to find this? We'll find it in areas where our skin, ligaments, and muscles, or even tendons, can start to rub against each other. So in this way, it will reduce that friction that could take place between, let's say, the bone and the tendon or muscle here. So we have a couple special names to describe these various bursa. We have subcutaneous bursa, which is going to be the bursa we find between the skin and our bone, such as the prepatellar bursa that we find sitting right on top of the patella here and our skin, and the olecranon bursa that we can have on our elbow. Then we have our submuscular bursa, which can be found between the muscle and the bone or between adjacent muscles. And an example of that would be our trochanteric bursa that we would find at the lateral hip. And lastly, we have our subtendinous bursa, which we would find between the tendon and bone. And an example of this would be our subacromial bursa in the shoulder and our suprapatellar bursa, which was that first one that I pointed out over here. A almost specialized type of bursa is called a tendon sheath. So our tendon sheaths are made up of connective tissue sacs that are going to surround a muscle tendon at places where the tendon crosses a joint. So in this case, we are talking about the ankle joint. And in these two, we will contain lubricating fluid. And like I said, they're similar to bursa, but they're going to be smaller and possibly elongated so that they can go through the full extension, not full extension, but a good extension of a tendon of a muscle. It's going to allow for smooth motions of that tendon during muscle contractions and joint movements. Now for our biggest structural classification, synovial joints, subtypes. These were based on the shapes of the articulating surfaces of the bones, and we've got 6 different synovial joint types. We have our pivot joint, hinge, condyloid, saddle, plane, and ball and socket. So we're going to go through each one of these and describe them a little bit more. We'll start with the pivot joint. This is when we're going to have a rounded portion of a bone that is enclosed within a ring that can be formed partially by the articulation with another bone and partially by a ligament. The bone rotates within this ring in order to its action, and it's functionally classified as a uniaxial diarthrosis type of joint. Uniaxial because it's only moving in one plane, and diarthrosis because it's a synovial joint and it's freely movable. So we have a couple examples of this type of joint. We have our atlantoaxial joint, and this is the upward projecting dens of the axis that articulates with the inner aspect of the atlas. And that's what we're taking a look at over here. This is a superior view of atlas, which is in yellow, and axis, which is in the blue color. So you can see the dens sticking out as being our rounded portion, and then the atlas serving as the ring. In fact, there's a facet for the dens here, and then there's a ligament that kind of holds it in place. And this will allow us to turn our head from side to side. So you can see that atlas rotating around. This would give us that head shake for no. Then we have our proximal radio-ulnar joint. And this is when we would have and I know you can't see this too well, but we would have the head of the radius that is encircled by a ligament that we'll talk about in a later section called the annular ligament. Annular means ring. So it's a ring that goes around the head and allows that radius or radial head to rotate so that the radius can cross over the ulna when we pronate. Next type is a hinge joint, and this is going to be a structure that is convex on one end, and it'll articulate with a structure that is concave at the other end of the bone. So it's going to only allow for a bending or flexion and straightening, which is extension. So just along the sagittal plane within a single axis. So we call this a uniaxial joint. Examples could be like our elbow joint between the trochlea on the humerus and the trochlear notch. It could be the knee joint, our ankle joint, and our interphalangeal joints within our hand or even within our toes. The next subtype is a condyloid joint or ellipsoid joint. This is going to take place when we have a shallow depression at the end of one bone that is going to articulate with a rounded structure from the other adjacent bone or bones. An example of this would be our metacarpophalangeal joints of the hand. So where we are going to have the heads of our metacarpals join the base of the proximal phalanx. And the radiocarpal joint. So that is going to be when we have the inferior aspect of the radius make contact with the scaphoid, lunate, and triquetrum. This is said to be a biaxial flexion and extension, and we can also have a side-to-side movement to display the fingers spreading apart, which would also be called abduction of the fingers. So biaxial because we've got flexion and extension in that sagittal plane, and then we have the spreading of the fingers, which is abduction. So we could say that is within the coronal plane. Now I just realized I did not want that picture in here, which I put on the next slide, because it's indicating for us a carpo-metacarpal joint. And I wanted to focus on this metacarpophalangeal joint for our condyloid joints. So I don't want any confusion. We're focusing on that there. Whereas with our saddle joint, this is going to be an articulating surface that has a saddle shape to it. So we are going to have a concave surface in one bone and a convex in another. So the bones fit together like a rider on a saddle. These type of joints are biaxial. So the best example of this would be that first carpo-metacarpal joint between the trapezium and that first metacarpal bone. And that is giving us the ability to have opposable thumbs. Another example would be our sternoclavicular joint. Now, before I move on to the next slide, you might be thinking, I really don't know what it means to have an opposable thumb. And so that's why I have this image over here, because the movement of the thumb is really unique. So our opposition of the thumb is bringing it over from its anatomical position and trying to touch each one of our fingers here. So being able to have this thumb reach over to the pinky. Go ahead and do that with your hand right now. You are doing opposition of the thumb. Now when you bring it back, that is called re-opposition of the thumb. Now, before we stray away, let's also talk about some of the other thumb movements. When we are going to pull that thumb out so that it is about 90 degrees up from the palm of the hand, that is going to be abduction of the thumb. Bringing it back into anatomical position is adduction of the thumb. And then if we were to bring that thumb in the way we see pictured here, that would be flexion of the thumb, and bringing it back is extension of the thumb. Now let's talk about plane synovial joints. These are going to be joints that have an ability to glide, in which our articulating surfaces of the bones will lay flat against each other, or they'll be slightly curved, and usually they're approximately the same size. So we've got some small movements that are constrained by ligaments, which ligaments have been pulled away from the examples that you see here. But we can also see a range of movements. And again, this has to do a little bit on the ligaments, where they're located and everything like that. So we say that it's multi-axial though, because we do have quite a bit of movement within the different planes here, but not all of our plane joints are technically going to be multi-axial. Examples, though, could be your intercarpal joints, so the joints between the carpals that we see over here. Same thing goes for our intertarsal joints. Also the joint between our acromion of the scapula and our clavicle. And then we've got our zygapophyseal joints that could be found between our superior articular processes and our inferior articular processes. So note how we have C1 articulating with C2's articular processes here. That's that zygapophyseal joint. And lastly, we have our ball and socket joint. This is going to have the greatest range of motion out of all the joints and will always consist of a rounded head of one bone that's going to fit into the concave articulation or socket of another. So we see this within the head of the humerus here in the shoulder and the glenoid cavity of the scapula. Same thing over here in our hip bone. Here is the head of the femur, and it is going to sit deep within the acetabulum of our hip. We are going to say that these joints are multi-axial because they are almost always going to be able to do all these movements: flexion, extension, abduction, adduction, and rotation. Now for our next section, we are going to talk about types of body movements. The type of movement that can be produced at synovial joints are determined by their structure type, and our movements will typically be paired, one being the opposite of the other, and we'll always describe these movements in relationship to our anatomical position. Our first pair that we're going to describe is flexion and extension. These movements will take place in our sagittal plane. When we have flexion taking place, it is a bending to decrease the angle between the bones, whereas extension is straightening to increase the angle between the bones. And then we've got lateral flexion, which I regrettably did not put a picture of what lateral flexion looks like. But imagine this individual would be bending their right side out to you, moving past your computer screen or telephone screen, wherever you're watching this. So it's really going to be a bending within that coronal plane of the vertebral column, or it could be of the neck toward either the right or left side. We can also perform things such as hyperflexion if maybe we have laxity within some ligaments or some tendons where we get excess flexion. And what we're seeing in this image over here is hyperextension, where we have an abnormal or excessive extension beyond the normal range of motion. Our next pair of terms is abduction and adduction. Now this is of course abduction and adduction, but I will always pronounce AB or AD just so it's a little bit clearer. And we'll see this movement take place within the coronal plane. When we perform abduction, we are moving that limb, let's say it's the upper limb, away from the midline of the body, which would be the center over here. So I always think I'm being abducted away from planet Earth. So we're moving that limb away. And for adduction, we are just moving the limb medially toward the midline of our body. So just the opposite direction, we are adding that limb back to the body. Now, sometimes we can perform a movement called circumduction. And so we can perform this at the wrist, we can perform it at the shoulder. If you're really talented, you can perform it at the hip, but it's going to be a circular movement where we're combining 4 movements together, and that's flexion, extension, adduction, and abduction. So try that yourself with your hand, or rather your wrist. So if you were to take your palm and move it forward, like if you're staring down at your palm right now, if you are to move it toward you, that's flexion. Moving it back away from you is extension. If you were to bend at your wrist so your thumb comes closer to your forearm, that is going to be abduction. And then if you bend it the other direction where your pinky side is moving closer to your forearm, that is adduction. So if you put it all together, you can rotate and spin your wrist. I just wanted to add in some pictures here showing you abduction and adduction of the thumb and of our fingers. So of our thumb, like I said, it's that 90-degree bend of our thumb. So it's sticking straight up from the palm, whereas bringing it back is adduction. And then if we're talking about the fingers, digits 2 through 5, if I spread them apart from one another, that's abduction, and then putting them back together is adduction. Next, we'll talk about rotation. This is going to be a twisting movement at the neck or the body. So that could be in reference to rotation of the head using our atlantoaxial joint, which is when C1 is going to rotate around the dens, which is sticking up right over here, of C2. And then other types of rotation, such as medial and lateral rotation, which we call internal and external rotation, usually will take place at the limbs. So it's when that anterior surface of the limb is going to turn toward the midline, that we will call it medial rotation or internal rotation. And when we are to turn that limb out so that we are turning away from the midline, that is called lateral rotation or external rotation. Our next two terms are supination and pronation, and these are really in reference to the forearm, although we do use these terms in the foot as well. You'll learn that more in an advanced course, especially if you go into the field of physical therapy. So when we supinate, this is going to be when our radius and ulna are parallel to one another. And essentially that is lateral rotation. So I want you to take your forearm and flip it so that we have the back of our hand is what we're looking at. So if you then rotate so that you are looking at the palm of your hand, that is lateral rotation of the forearm, which ends up being supination. So it's as if you're holding a bowl of soup. That's how we can remember the position for supination. I think this is a cup of green tea, but we're going to pretend it's soup. Anyway, if we were to throw that soup on the floor and flip our hands so that we're looking at the back again, that would be pronation. And that allows the radius bone to rotate over the ulna at the proximal radioulnar joint. And this truly is medial rotation of the forearm. Next, concentrating in the foot area, we are going to talk about dorsiflexion and plantar flexion. Dorsiflexion is going to be when we have lifting of the front of the foot, which we are going to call the dorsum of the foot, toward the anterior leg or the shin. So you can see this individual dorsiflexing his right ankle. And then plantar flexion would be when we lift our heel, so you can see that in this picture too, up from the ground and we are pointing our toes downwards. So that is plantar flexion. Next we have inversion and eversion. This is a plane joint movement of our tarsal bones. So it really doesn't take place at the ankle joint, it's taking place in the foot. So when we have inversion taking place, we are taking that bottom of the foot and moving it toward the midline. So you could see it taking place over here as well. And our foot has a greater range of inversion than eversion to help stabilize the foot during walking or running, or even when we are doing those things on uneven surfaces. When we perform eversion, we are taking the outside of our foot and turning the bottom of it away from the midline. So this would be eversion right here. I always like to think about the way I try and stop when I go skiing or when I'm ice skating. If I kind of point my toes toward one another and lift up that lateral aspect of my foot, that is eversion, and you can stop yourself from gliding on ice. Next up is protraction and retraction, and we're going to use these terms in reference to the scapula and the mandible. So when we have protraction of the scapula, such as this woman over here doing a plank, the shoulders are going to move forward, which is going to round out our shoulders, and this is also known as abduction of the scapula because the shoulder blades are moving away from the midline. Then we have retraction of the scapula. That is when they are pulled back posteriorly and medially so that we are having these shoulder blades making their way closer together in the midline. And this is also known as adduction of the scapula. Now when it comes to our mandible, protraction is going to be when we take that lower jaw, the mandible, and push it forward so it sticks out. Whereas retraction is pulling it back in. Next we have depression and elevation. These are movements of the scapula and mandible once again. So if we were to have elevation, that means we have a upward movement of the scapula or the mandible. So here where we have the person shrugging their shoulders, that is elevation of the scapula. And in the mandible, it would be where we would be bringing the mandible up. Then we have depression. That is when we are going to have downward movement of the scapular mandible. So here we really have to work to pull our shoulders down and away from our ears to perform the exercise properly. So that's depression of the scapula. Or we can have depression, which you see well here on the genie, where we are going to bring that mandible further down. Another movement in the mandible is lateral excursion. So this is when we have a side-to-side movement of the mandible, which you see pictured over here. That lateral excursion could be to the right or the left and will perform that grinding movement. Medial excursion is just returning that mandible back to its resting position in the midline. And then we have superior or upward rotation and inferior or downward rotation of the scapula. These are defined by the direction of movement of the glenoid cavity. So when we have superior rotation or upward rotation, that's when this glenoid cavity is going to move upward as the medial end of our scapular spine is going to start to move downward. So when we go to raise our hand, we actually have to have a muscle that allows us to rotate the scapula. Otherwise, we will have a collision between the greater tubercle of the humerus and the acromion. So if we are to rotate this, that moves that glenoid cavity further up, and we avoid the collision and can raise our hand. The other movement, our inferior or downward rotation, occurs during limb adduction when there is a downward motion of that glenoid cavity and an upward movement of this medial end of the scapular spine. We've talked a little bit about opposition of the thumb movement already. We are taking the tip of that thumb and bringing it into contact with the tips of our fingers. And this is able to take place because of a combination of flexion and abduction of the thumb at that first carpometacarpal joint. Reposition is, again, just bringing it back to its anatomical position. And here's a nice table that your book put together, putting the types of synovial joints together with their movements and the examples that we discussed. In our next section, we're going to talk about selected synovial joints and just get to know them a little bit better. Our first type is going to be that zygapophyseal joint, and that is the articulation between the superior articular facet and the inferior articular facet. So in this case, it's between atlas or C1 and axis at C2. These are plane joints, which you can kind of tell based on its flat surfaces here, but it's going to allow us to have limited motions between these vertebrae. And specifically along the vertebral column, the cervical and the lumbar regions have the greatest ranges of motion. Then we have our atlanto-occipital joint, which you could see pictured over here and here. This is an articulation between C1, atlas, and the occipital condyles that we would find at the base of the skull. And this articulation has a U shape, which you can kind of see on these superior articular facets of the atlas here, that has the curvature to allow the skull to be able to rock back and forth, allowing the yes motion to take place. And then last on the slide, we have the atlantoaxial joint. That's going to be the articulation between the atlas and axis through three articulations. We have the two zygapophyseal joints, which we pointed out over here. These joints, by the way, are taking place all throughout the vertebral column, right? And then also the pivot joint that would take place from the dens, making contact with the articular facet for dens on the atlas and this ligament holding it in place. Now let's shift gears to talk about the temporomandibular joint, or the TMJ. That's going to be where the mandibular fossa, that depression that we find in here, comes together with the articular tubercle of the temporal bone. So you can see that mandibular fossa over here, and it's coming together with the mandibular condyle over in here. Now this joint is going to allow for depression and elevation of the mandible and that lateral excursion we discussed, and it contains a flexible articular disc that we had a couple slides ago. And this disc helps to smooth out movements between the bones. The full function is to have that gliding and hinge motion of the mandible, which can result in a forward and downward motion of the condyle and mandibular depression. We have reached the shoulder now, which we are going to call the glenohumeral joint. This is when we have an articulation between the head of the humerus and the glenoid cavity of the scapula. This is one of the joints that has the greatest range of motion in the body, which comes from a lack of structural support, which leads us to a loss of stability. So it's that stability rule that we talked about at the beginning of this lecture. Now we have a few special structures to assist with this joint. We have our glenoid labrum, and this is going to be made up of a fibrocartilage that we'll see right along in here that will help to deepen the socket of the glenoid cavity. We also have some ligaments associated, such as the coracohumeral ligament that will span from the coracoid process of the scapula to the anterior humerus. And then we have 3 separate glenohumeral ligaments that are located on the anterior side of the articular capsule. Now that's not pictured so that you can see the actual joint without the ligaments in the way. And these ligaments are all going to help to strengthen the superior and anterior capsule walls. And even though we have all this support through the capsule and the ligaments, the primary support for the shoulder joint is actually given by the muscles that cross the joint, namely the rotator cuff muscles. Those muscles are going to form a fusion of muscle tendons, which is known as the rotator cuff. Moving further down the upper limb, we have our elbow joint, and this is made up of the humero-ulnar joint, which is an uniaxial hinge joint. You were only able to really flex and extend here, and that joint could be found between the trochlea and the trochlear notch of the ulna. Now the humeroradial joint and the proximal radio-ulnar joints are also associated with the elbow joint. And surrounding all of these structures, we are going to have some ligaments. So first, we'll talk about the ulnar collateral ligament. This is triangular shaped and can be found on the medial aspect of the elbow. It arises from the medial epicondyle of the humerus and attaches to the medial side of the proximal ulna. The radial collateral ligament, which we see pictured over here, is a ligament on the lateral side of the elbow that arises from the lateral epicondyle of the humerus and then blends into the lateral side of the annular ligament. Now we've talked about the annular ligament already, but here it is again. So let's take a look at it. It is going to encircle the head of the radius that we would have in this area. That would allow it for rotation of the radius during supination. We've made it down to the lower limb, and we are going to discuss the hip joint now. As we said before, it is a multi-axial joint, a ball and socket joint, in which we are going to have that head of the femur articulate with the acetabulum. This type of ball and socket joint is going to have more stability than our shoulder joint, and it's going to have weight-bearing ability. Even though this socket is pretty deep, we're still going to have a acetabular labrum, and this is going to be made up of fibrocartilage that will deepen the pocket even further. We also have some ligaments for support. There are 3 ligaments. We have our iliofemoral, our pubofemoral, which is pictured over here, and our ischiofemoral, which you can see right along in here. Now, if we were to cut these ligaments out of the way and try and pull the head of the femur out, There's this little tiny ligament here, the ligament of the head of the femur, or ligamentum teres, that is going to span between the acetabulum and that femoral head at the fovea. Now for our giant joint, the knee joint. This joint consists of 3 different articulations that is then enclosed within a single articular capsule. And so the first joint is going to be the femoropatellar joint. This is found between the patella and the distal femur. Next, we have the medial tibiofemoral joint. That is going to be found between the medial and lateral condyles of the femur and the medial and lateral condyles of the tibia. And lastly, we have our lateral tibiofemoral joint. So as I said, this is the largest joint in the body, and it is going to serve as a hinge joint because we can flex and extend within the sagittal plane, and we can have a little bit of rotation when the knee is flexed, but that is about it. Next, let's talk about some of the ligaments around this joint. We have the patellar ligament here that we already talked about, spanning from the patella to the tibial tuberosity to give support and stabilization of our knee joint. Then, if we were to remove the femur out of the way and look down on the tibia, we would see our C-shaped medial and lateral menisci. Meniscus is singular, menisci is plural, and it is made up of fibrocartilage and can attach to the tibial condyles to help provide padding between the bones. Next up, we have our fibular or lateral or peroneal collateral ligament, and this is spanning from the lateral epicondyle of the femur to the head of the femur. And then we've got our tibial or medial collateral ligament that is spanning from the medial epicondyle to the medial tibia. Lastly, if we were to remove the patella and bend the knee, we would be able to see the anterior cruciate ligament, but we can't do that here. So instead, we took that femur off and we're looking down on it. So here's our anterior cruciate ligament. And then here posteriorly, we find our posterior cruciate ligament. And these are anchored inferiorly to the tibia at the intercondylar eminence, where we have those rough bumps between the 2 condyles. And it helps to create an X. And in doing this, it helps our PCL prevent the femur from sliding anteriorly off the tibia, essentially allowing that tibia to fall backward, whereas our ACL is preventing hyperextension. So if we were to tear our ACL, this tibia would be able to shift forward, which we don't want. The last type of joint or special joint that we are going to discuss is the ankle joint, also known as our talocrural joint. And this is an articulation that takes place between the talus, or the tallest bone of the foot, and the distal ends of the tibia and the fibula. We are going to have the strongest connection for weight bearing with the talus and the tibia together, but then we also have, forming the joint, the medial and lateral malleoli on each of those bones. This type of joint is going to be uniaxial, meaning that we are only moving within one plane in doing flexion and extension, which really is dorsiflexion and plantar flexion. So the last thing we are going to touch on is in section 9.7 on the development of joints. Our embryonic tissue is going to give rise to all of our bones, cartilage, connective tissue, and is called mesenchyme. Remember I said mesenchyme is kind of that cell that is your inner 5-year-old, and it can become almost anything that it wants. That's what's going to happen here. So when we have intramembranous ossification, the mesenchyme that sits between the areas of bone will become fibrous connective tissue and fill those spaces between the developing bones, and we will get fontanelles as a result, which will then later turn into a suture. Then if we are going through endochondral ossification, the mesenchyme starts to accumulate and it's going to differentiate into hyaline cartilage, which is then going to be replaced by bone, and the mesenchyme between bones becomes fibrous connective tissue and creates suture joints in the skull. So we've covered the two different ossification processes in how it would create joints within the skull, but what about the joints throughout the rest of our body, especially within our limbs? We are going to start to see those limb buds appear around week 4 of gestation, and they will start to grow and elongate. And in the areas where we have mesenchyme, we'll start to see it differentiate into hyaline cartilage. That joint is then going to form an interzone, and you could see this in the image on the right hand side over here. My mouse keeps disappearing, so I don't know if you could see it, but the interzone is going to be in the middle there. So our cartilage models have been formed, and then what we can do is start creating a joint cavity where the space is being created between the bones, and then we will also develop articular capsules and supporting ligaments for this joint. So that is it for Chapter 9. Please let me know if you have any questions.